Everyone, and please excuse my grating voice. I'm struggling with a cold, but I'm really excited to be able to introduce Dr. Steinberg this afternoon. He will be presenting important information about DCM and just a little bit about the Canadian SADS Foundation and our intentions with these webinars. We feel that they are, because we have people like Dr. Steinberg that are prepared to donate his time and put together presentations like this, it provides the Canadian SADS Foundation with an opportunity to build a library of information for patients, for healthcare professionals, and for anyone else who wants to access this information. So thank you to those who have arrived and are supporting us. And this presentation will also be available on YouTube after, probably by tomorrow. And we will also continue to promote it through social media for those people who were not able to attend in person, but in fact want to view this. So I will get around now to introducing Dr. Steinberg. I don't know if I can really do justice because I have trouble reading and looking into the camera at the same time. But Dr. Christian Steinberg is a cardiologist, electrophysiologist, and specialist in inherited arrhythmias and cardiogenetics. And he is the director of the Inherited Arrhythmia and Cardiogenetics Clinic. He is an associate professor of medicine at Laval University. He is a clinician researcher, and his research interests include inherited arrhythmias and genetic cardiomyopathies, cardiogenetics, applied genetics, and unexplained cardiac death and cardiac arrest. So I will let him fill in the blanks with anything I've missed of importance about him. And I turn this important webinar over to Dr. Steinberg.
Yeah, first of all, thank you very much for this very kind introduction. I'm very pleased and honored actually to get the opportunity to speak about hereditary dilated cardiomyopathies. It's an important topic here at this SADS webinar hosted by the Canadian SADS Foundation. And let's right away get into it. Please don't hesitate to let me know if there's any problems with the acoustics or anything. I have no conflict of interests related to this talk. And I was told that we have a mixed audience consisting of patients, families, healthcare professionals. So I hope the presentation will reconcile the needs of everyone. And here are the objectives. I hope that at the end of this presentation, you will agree with me on the importance to recognize hereditary cardiomyopathies among the differential diagnosis of apparently unexplained DCM. Dilated cardiomyopathy is often just abbreviated as DCM. We shall recognize the importance of a systematic stepwise diagnostic approach when facing a diagnosis of unknown DCM. And I hope also to convince you to recognize the role and importance of a specialized cardiogenetic clinic for the diagnosis and management of patients and their families. So first of all, for those who are less familiar with this, what is a cardiomyopathy? It's actually a description of, it means it is a primary disease of the heart muscle, the myocardium, that causes a cardiac dysfunction. So in contrast to coronary artery disease or a valve problem, which may secondarily weaken the heart muscle. In a cardiomyopathy, the heart muscle is primarily affected. And there are different types of cardiomyopathy, and all of them are big families. Today, we will speak about the family of dilated cardiomyopathy. Another important family is hypertrophic cardiomyopathy. One of my colleagues, I think, will speak over the next weeks about that. And so what is a dilated cardiomyopathy, if you have to explain that? Below you find the international definition from the guidelines. In more practical words, we could say it is a cardiomyopathy that is characterized by a progressive enlargement of the ventricles, mostly of the left ventricles, sometimes of both ventricles. And this goes along with the stretching and thinning of the myocardial muscle that can even get scarred and weakens and is associated with the decline of the contractility. The main parameter for this is for the strength, the contractility of the heart muscle is what we call the ventricular ejection fraction. There's a left ventricular ejection fraction, LVEF, and also a right-sided. And what it does is that a cardiomyopathy results then in heart failure with typical symptoms and may even cause electrical problems, heart rhythm disorders that may be even life-threatening when arising from the ventricle. Patients affected by a cardiomyopathy will require standard heart failure medication. A substantial proportion of them will need specialized devices, implantable defibrillators, sometimes even so-called three-wire systems of cardiac resynchronization therapies. For those who have recurrent and refractory arrhythmia, a certain proportion will require procedures in the electrophysiology lab, where we perform what is called a catheter ablation. And also, unfortunately, a significant proportion of patients will actually develop end-stage heart failure over time and may require a mechanical heart or a heart transplant. So it's actually an important group of cardiac diseases. The challenge with the DCM begins right from the beginning with the diagnosis, because DCM is actually an umbrella term that may describe or may be related, to a whole bunch of different causes. You could also compare it to this very delicious French recipe called ratatouille, which it's like basically a mixture of all kinds of vegetables that you can cook. It's very delicious, but the differential diagnosis of DCM resembles a little bit at this. This slide is just to give you an overview of the broad spectrum of differential diagnosis. The blue cases indicate different categories that may cause or manifest as a DCM. We won't go through all of that, but you can see there are many different mechanisms and causes. And today we want to focus on the hereditary cardiomyopathies, well, the DCMs. So why should we think about hereditary DCM? Because dilated non-ischemic cardiomyopathies are more common than you may think. At least 40–50% of patients in a standard heart function clinic present a DCM. Roughly 31% of those have a so-called idiopathic sporadic cardiomyopathy. So it means we don't know why. And at least a quarter of them have potentially a genetic underlying reason. They are genetic cardiomyopathies. The prevalence of so-called idiopathic DCM shows important geographic and ethnic variability. The true prevalence remains unknown, but is probably underestimated. More recent data suggests that at least in 1 out of 250, 1 out of 500 may actually have a genetic cardiomyopathy. And this is actually a similar prevalence to hypertrophic cardiomyopathy. So when should we suspect a genetic cardiomyopathy? In everyone? No, I think it's like we need a systematic approach when we have an unexplained DCM, but there are key elements, clinical or in the history key elements that might orientate us. So, and we have to look for these key elements. So patients with an unexplained DCM who present at least one of the following are suspect to have an underlying genetic cause. Clearly a family history of unexplained cardiomyopathy, manifestation at a very young age. If the DCM presents with heart rhythm disorders, either conduction disorders, AV blocks, multi-level blocks, multifascicular blocks, or ventricular arrhythmia, these presentations combinations are usually suspicious. For those who have a very severe presentation right away from the beginning or a rapid evolution towards end-stage heart failure, well, we should always make sure that there's not an underlying genetic cause. And as a fifth category, I would like to add, we should also rethink a diagnosis in those who have an unexplained DCM, have good or optimal medical treatment, but do not improve over several months. Sorry. And to give you an idea about how these cases may present, I just would like to introduce a clinical case from our clinic that just occurred here at the beginning of this summer. This is a 26-year-old female patient who was admitted to our hospital for new onset heart failure. She was fluid overload, lung edema, peripheral fluid overload, very severe, and she was diagnosed with a severe non-ischemic DCM. For those who are familiar with the values, massive dilation of the left ventricle, 136 milliliters per square meters, and there was a biventricular dysfunction. Left ventricular ejection fraction was 10%. Just to remind you, normal value is 55 to 60, and the right ventricular ejection fraction was 28%. Normal value is usually 45. We found 2 apical thrombi in the left ventricle. There was quite a bit of scarring of the myocardium, and the coronary angiogram was normal, so an unexplained DCM. Here you can appreciate the views from the initial echocardiogram. On the left side, you see what is called an apical four-chamber view, and you may appreciate a massive enlargement of all 4 chambers, in particular of the left ventricle that is barely contracting, just oscillating a little bit with an ejection fraction of 10%. The mitral valve leaflets are stretched and cause what we call a functional tenting. It means the leaflets are so stretched and the annulus is so dilated that the valve is leaking. You can see this here on the right, a severe functional mitral valve regurgitation. If then we have a look at the cardiac MRI, here on the left side, the MRI confirmed our findings of the severe dilated cardiomyopathy, and you can see here in black at the left ventricular apex 2 large-sized thrombi, so the patient required anticoagulation. The images on the right side are views from the MRI sequence that shows myocardial scarring, what is called late gadolinium enhancement. You may appreciate here at a closer look a fine white line inside the dark myocardial wall. So this fine white lines represent myocardial fibrosis, scar tissue, and it affected multiple segments of different arteries. Clearly in the middle of the muscle, this is non-ischemic, and this was quite important. So we could eliminate standard case causes like metabolic or toxic causes. And when we then performed a thoughtful 3-generation family history, we could actually link our patient here with a red star via her maternal grandmother to another family that is already followed at our clinic and that is known for a well proven and established genetic cardiomyopathy. And it is the gene that causes it is actually BAG3. It's a standard DCM gene. And our patient too, finally, we could prove without any doubt that she was also a heterozygous carrier of the same variant. Interestingly, the patient did not inherit it from her father, as we thought initially, but from her mother, who is unrelated to the father's family, but who comes from the same region of our province. So there might be something like a regional founder variant problem. So we are still investigating on her. So, and as you can, and I hope that this large differential diagnosis and the complexity of cases makes it clear that it is crucial to have a systematic, structured diagnostic approach when facing a DCM. So the first steps are the baseline exams, including an ECG, an echocardiogram, and we have to eliminate coronary artery disease either by an angiogram or a CT. Why? Because coronary artery disease is so common, and it's actually in 90% of cases of new onset heart failure, it's actually coronary artery disease. After that, it is important to perform what is called advanced cardiac imaging, including cardiac MRI and a PET-CT. You can see samples here on the left side. Why? Because it can eliminate some of the other important causes of DCM that we have seen before. And these are standard exams that are available at all specialized tertiary centers and part of the standard workup. And in parallel, it's always important to eliminate other common causes of a DCM, like toxic metabolic causes, alcohol, drugs, previous chemo or radiotherapy, as well as some reversible causes, for example, what we call a tachycardiomyopathy. It means sometimes severe heart failure and even DCM kind of manifestation related to a sustained electrical disorder, and this might be reversible once you fix the electrical problem. The question of myocardial biopsy arises very often. It's actually a test that is infrequently used because it's not very helpful in the diagnosis of an unexplained DCM. It's usually reversed for very hyperacute or fulminant presentations, because in those cases it's important to eliminate a few highly aggressive inflammatory autoimmune diseases that may require special treatment. However, most of our DCM patients present with subacute chronic symptoms at the time of presentation. This is why myocardial biopsy is rarely needed. Once all this on our to-do list has been checked out and we could clear the usual causes and we still do not know why the patient has a DCM, well, then it's time to refer the patient to a cardiogenetic clinic. And the cardiogenetic clinic actually reflects the growing role of molecular medicine in cardiology, but also elsewhere in medicine, because even with advanced imaging like cardiac MRI or standard histology, these diagnostic tools have well-known limitations. Most of the time on myocardial biopsy and even MRI, the findings for an unexplained DCM are non-specific, and the reason why we have to zoom in even deeper to look for a molecular proof or explanation for what is going on. And this is usually done in a cardiogenetic clinic. This slide is important for me and my colleagues to emphasize that the cardiogenetic clinic is not a standalone player. It is actually, we are team players. We see ourselves as allies in the general team that is gathering around the patient and their families, including also the referring cardiologist or other physician, family doctor, and other specialists to provide an optimal diagnosis and care. So what is a specialized cardiogenetic clinic? Well, it is a multidisciplinary clinic consisting of many different healthcare professionals, again, gathered around the patient and his or her family. Yeah, it includes obviously an adult electrophysiologist with a special training in inherited arrhythmia cardiogenotics, and typically also its pediatric counterpart. But we also have specialized clinical nurses in our clinics, medical geneticists and/or genetic counselors, and quite a few. And sometimes we need also help from psychologists for patients and their families. What are our activities? Well, there are more than people might think. Obviously, a big chunk is the evaluation and genetic testing of the index case with the DCM. However, it doesn't stop there, because this often includes also the stratification of the risk of sudden cardiac death and all the question, does my patient need a specific device? Does he or her need a defibrillator? We organize and coordinate the genetic family screening. We provide follow-up and adjustment of specific disease-related medication, and more specific cardiomyopathy-related medication is now arriving on the market. Genetic counseling with regard to pregnancy is another important aspect. A lot of our patients are young and women. We have a lot of women at childbearing age. Sometimes prenatal genetic testing is performed if wished by the patient. We are electrophysiologists, so if the patient has electrical problems related to the heart or elsewhere, well, we take care of it, of course. And not to forget about teaching and psychological support of patients and family. To understand the problems and principles of genetic DCM, I would just like to introduce a few genetic concepts for those who are less familiar. So as maybe most of you know that we have for each gene 2 copies in our genome, in our cells, 1 copy from our mother, 1 from our father. And most of the genetic DCMs are caused by an autosomal dominant inheritance. It means that one of the 2 copies of the gene has a mutation that may, in a certain proportion of patients, cause the disease. So the chance of transmission to the next generation is 50%. It is important to understand that the presence of mutation does not equal presence of disease. This comes to the concept of variable expression in penetrance. Penetrance is the proportion of patients with a genetic mutation who will develop some kind of disease traits, and the degree. This is what is called the expression, the degree, the severity of the disease. It's also important to appreciate that there's a significant proportion of so-called asymptomatic gene carriers for most genetic substrates. So genetic testing, how does this work? So it starts with, it is a DNA test. It starts with a blood or saliva collection. This is the easy part. And then subsequently transferred to a specialized laboratory where DNA extraction is performed. And then the sequencing, looking for a mutation abnormality in the genes of interest, is then performed, creating a huge amount of bioinformatic data. And once after a complex analysis process and quality control and multiple verifications, we will come up with a report that may or may not indicate that we found something. What are the timelines? Usually it takes about 1 to 3 months to obtain the final report after the collection of blood or saliva sample. And interpretation of a genetic test is not as easy as many even physicians think. It's not like a standalone test and you just tick in something and we get an answer, because interpretation may be challenging because it's not only black or white, it may be gray. It is important to understand that if we find a mutation, to make sure, does this mutation, this gene, can it actually explain the patient's disease? Because all of us, we are carrying 4 to 5 million mutations in our genome who are basically benign, the majority, and they are simply part of our genetic individuality. And there are technical limitations because even in 2024, there are cases of strongly suspected hereditary cardiomyopathy that we cannot yet prove on a molecular basis. And genetic testing has implications, medical implications, social implications, sometimes occupational implications, can have ethic implications. To guide our interpretation with the genetic test results, so we have now a structured framework in forms of guidelines since almost 10 years. Based on a lot of research and to guide us how to interpret a genetic test result. Because if we find a mutation, we have to classify it into 5 categories that are here in red, either a pathogenic or a likely pathogenic variant, the variant of unknown significance. This is basically the large gray zone, or is it a likely benign or clearly benign variant? And only the pathogenic and likely pathogenic variants are so-called clinically actionable results. It means these results can or should be used to establish a diagnosis or organize like genetic screening. This slide gives you an overview of the genetic substrates of hereditary DCM, and I don't want to go through all of this, but it is just to show that these genes encode proteins that have an important function inside the cardiomyocytes, what you can appreciate here in this figure. These are either proteins or the contractile elements, so sarcomeric proteins inside the cardiomyocytes, proteins of the cytoskeleton, proteins of the cell signaling machinery, or even proteins from the nucleus. By far, the most common genetic substrate are mutations in the gene Titin, TTN. It is for familial as well as sporadic DCM the most common genetic causes, but there are others. And if you ask us what is the genetic yield of testing, it is in familial forms of DCM 20 to 40% with the current technology, but this may change over time. And it is very important to have a profound knowledge of the medical literature and science to be able to identify genes that are undisputed and can be related to genetic DCM, because the genetic laboratory will often also test a bunch of other genes associated with our target genes in the panels, and mutations in unrelated genes will not necessarily explain the disease. And only those genes that have been shown to have definitive and strong evidence should and can be used to establish a genetic diagnosis. And by the way, BAG3, the gene that we just identified in this young lady, is also part of this typical DCM genes. From a clinical and prognostic point of view, it is also important to know how the DCM presents. Does it only affect the right or the left ventricle or both? What we learned over time is that depending on the underlying gene, the phenotype, it means the manifestation, can be characterized by either a predominantly right ventricular or a predominantly left ventricular or a biventricular DCM. And some of these genes are typically associated with electrical disorders, either conduction disease or malignant ventricular arrhythmia from the ventricle. And those DCMs who have an genetically increased risk of ventricular arrhythmia, so it means the risk is independent just from the left ventricular ejection fraction from the decline of contractility, those DCMs are typically named arrhythmogenic cardiomyopathies, ACMs. So DCM and ACMs, there's a distinct overlap. How do these DCMs manifest? So we see frequently sex-specific differences between women and men. For many genes, males show typically an earlier disease onset and more severe manifestations. As outlined before, the penetrance is variable, but some genetic substrates have up to 100% like a full penetrance. However, the disease expression, the degree of disease severity may be different. And it is also important to understand that genetic test result has not only a diagnostic, but also sometimes a prognostic impact, because depending on the gene, we already know about the probability upfront if this patient will have a more severe course, if he has a greater chance to evolve towards end-stage heart failure. Some genes, like for example, LMNA, that is a substrate of so-called cardiac laminopathies, has a very high chance to develop towards end-stage heart failure. At least a quarter of these patients will require mechanical heart or a heart transplantation, for example, compared to MYBPC3 or RBM20. The underlying genetic substrate may also determine the mean age of manifestation of when this occurs. For example, RBM20 has a lower risk to develop end-stage heart failure compared to LMNA. However, when it occurs at a significantly younger age compared to others. What you can appreciate here, the mean age is 29 years compared to early or later 40s. Also, part of this genotype-phenotype correlation is actually the risk of co-associated electrical problems. For example, conduction disorders are very frequent in cardiomyopathy, over 70% compared to very rare in, for example, phospholamban or MYBPC3. And not only conduction disease, also the risk of malignant ventricular arrhythmias, and with this, the risk of sudden cardiac death differs between different genetic causes of DCM. And all this information is very important for us in the cardiogenetic clinic for the management, the risk stratification, and the choice and timing for a device decision. Another important element related to the underlying gene is actually the response to heart failure medication. We know since several years that different genes have a different response rate to heart failure. This is a figure from a study where they looked at a increase of the left ventricular ejection fraction of at least 10% as an endpoint under optimal heart failure treatment, which was similar in all different groups of DCM patients. And what they observed was that, for example, Titan DCMs responded significantly better compared to LMNA-related DCMs or G-negative DCMs. For example, also cardiac resynchronization therapies for certain genetic substrates is very modest. For all cardiac laminopathies, only 40% will show some improvement under resynchronization therapy, even when you have an optimally placed left ventricular lead. And when we go to family screening, we need to have the same systematic and structured approach like for the index patient. On a regular basis, we get the patient referrals without seeing the index case, and somebody refers a patient and said, well, in my family, they found this and that genetic cardiomyopathy. Am I at risk? And this, for example, is the case of a young man who was referred by his family physician for an exercise treadmill test because he told his family doctor there is a genetic DCM in my family. And the cardiologist who supervised the treadmill test heard this history and then got very concerned and organized on a very urgent basis an echocardiogram, a cardiac MRI, and sent the patient to me. And then I did a detailed family history with them, and that is all good. And then I asked him the one question is, how are you genetically related to the index case? And then it turned out that this young man was actually far away from the index patient who was actually a paternal first-degree cousin, right? So instead of rushing in and doing exams on this individual, it would have been way more important to actually investigate the still living parents of the deceased index patients. And even after that, if it would come from the paternal side, we should investigate this man's father first. So this is just an example to show how important it is to be structured, to do a detailed family history, and to start with the right individual. A few words to Titan DCMs because it's the most common type. Titan is the largest human protein in our body. It's an important protein for the cardiomyocyte. It provides actually the elasticity of the heart muscle, and it acts a little bit like an elastic spring to anchor the different contractile elements. And this protein exists in 6 different subtypes called isoforms, and to add more complexity, there is differential expression of isoforms in the adult heart. So they are not expressed in the same way between the right and the left ventricle, and even inside the left ventricle, there's under normal condition a certain ratio between these different subtypes. And this is important to keep in mind because given the fact that this gene is so huge, it's on chromosome 2, has 364 exons, is huge. It means that it is also at risk to have a lot of meaningless benign mutations that are circulating around. We learned over time that those Titan TTN variants associated with the genetic DCM are typically what we call a truncating variant. It means it is a mutation that results in a premature stop of the translation or the production of the protein. So patients lack Titan protein, or they only have protein remnants that are not very functional. And because of the big size of the gene, there's an increased genetic background noise. Over 2,500 different variants circulate in African populations and over 3,000 variants in Caucasian populations. And this is important when I mentioned like test interpretation is difficult because at least 1 to 3% of the general unaffected population will harbor a rare truncating TTN variant without ever developing a DCM. And are there a few key elements to help us to guide the prediction of pathogenicity? There are. So not only that we are looking for truncating variants, we are also looking for truncating variants affecting at least 5 of the 6 different transcripts, meaning the different isoforms of the protein. Ideally, it should be a mutation that affects consecutive exons. And we also discovered that these pathogenic mutations are typically clustered in what is called a mutational hotspot. A lot of the DCM genes, not only Titin, have zones along the gene that are more prone to harbor pathogenic mutations than other zones. And in the case of Titin, most pathogenic variants are localized in the so-called A-band region. It's just a functional region of the protein. Ethnicity can help us a little bit. It has been shown that, oh, sorry, it's just jumping forward. It has been shown that truncating variants in individuals of African descent are less frequently associated with the DCM compared to Caucasians. And I know that this slide is a little bit technical, but it's just to illustrate that it is not so easy to interpret the genetic test results, and it's just not like receiving a piece of paper and then all answers are clear. Another example of a genetic DCM are MYH7 related DCMs. So MYH7 is also a gene that can cause hypertrophic cardiomyopathies, so a different family of cardiomyopathies. However, a different set of mutations can cause a DCM-like phenotype, and it's not the same mutations compared to those that cause hypertrophic cardiomyopathy. This form of DCM, what is interesting, is characterized that a significant proportion of up to 16% will develop a DCM at the pediatric or adolescence age, which is usually uncommon for genetic DCMs. Most genetic DCM will not manifest before 20-25 years. However, MYH7 has a tendency to start much earlier. Roughly a third of these patients will show a few particular finding on cardiac imaging that is called ventricular non-compaction. I don't want to go into too much detail here, but it can give a clue. The overall response rate to a heart failure medication is relatively good, it's 72%, and at 28% respond not at all or minimally. This is what is called a LVRR rate, which means left ventricular reverse remodeling rate. On the other hand, it's one of the genes where the risk of sudden cardiac death and ventricular arrhythmia is much lower compared to other genes. The risk of ventricular arrhythmia is only 1% at 5 years, which is much lower compared to LMNA, RBM20, or FLNC, for example. Again, it's one of these genes where we see sex-specific differences. You can appreciate from the figure on the left side that males may develop the disease a bit earlier and are at increased risk of adverse events. The figure on the right side shows a histogram of the age distribution at the time of disease manifestation. And as mentioned before, there's 16% who may start the disease under the age of 18. So this is important for screening and follow-up. Also, 24% of asymptomatic variant carriers will develop a DCM over time, and the age-dependent penetrance is quite high. By age 80, however, a significant proportion of patients will only develop mild disease. So, what are the future directions? Obviously, the great promise or hope is gene therapy, and it's actually arising at the it's emerging at the horizon. I don't want to go into detail about all of these and the different technical forms of gene therapy. I just want to mention that the ultimate goal and our ultimate wish to cure genetic DCMs will be gene therapy. And I think we will all see the beginning of this over the next 5 to 10 years. The first studies in human, the first phase 1 and 2 studies in humans are underway. And we will see how this will add to our therapeutic arsenal for patients, but it is the hope that maybe one day we will be able to correct the genetic mutation. And if this is done at an early stage, that patients probably will never develop the disease. If you ask yourself, well, how can I find such a specialized cardiogenetic clinic? I'm a patient, I'm affected, I'm a doctor, I have a patient with this, I struggle with this. Here's the good news, you are not alone. This is like a screenshot from the Hearts and Rhythm Organization webpage, acronym HERO. You see the web link below. What is HERO? HERO is a pan-Canadian platform and network of specialized cardiogenetic clinics, physicians, researchers, other healthcare professionals, but also patients, patient partners, patient support groups are brought together on this platform. And it is used for clinical exchange. It provides information where to find the nearest cardiogenetic clinic in your province or region. Information material for patient partners can connect patient or patient groups with each other. It's a research platform, but it is basically a great network for healthcare providers and patients and their family to get information, to find resources, to find help nearby. The good news is right now, virtually in all Canadian provinces, there are specialized cardiogenetic clinics. So if you need a resource, if you're looking for one, have a look at their homepage. And with this, I would like to conclude. Hereditary dilated cardiomyopathies represent a significant proportion of patients with the so-called idiopathic DCM. Using a systematic approach, an underlying genetic substrate can be identified in 25 up to 40% of cases. In addition to its diagnostic value, genetic test results may also provide prognostic value for patients with hereditary DCM and may influence management decisions. And a specialized cardiogenetic clinic provides the expertise and resources for comprehensive genetic screening, risk stratification of index patients, and management of patients and their family. Find the closest cardiogenetic clinic in your province on the HERO web page. And with this, I would like to terminate and thank you all for your attention.
I think I can speak now. Can everyone hear me? Can people hear me? Can you hear me, Dr. Steinberg?
Yeah, very well.
Yep,
Okay,
I can
good.
hear you too, Pam.
Okay, thank you. Thank you to everybody who attended. Thank you to Dr. Steinberg. This was, I thought, a fabulous presentation. It really brought a lot of concepts together for patients. I'm going to open it up for questions if anyone has any. And I also just want to say that the Canadian SADS Foundation is in the process of producing materials that we will be posting into social media with regards to information about cardiomyopathies. And one of the things we have planned for is to help patients identify places across this country where they can seek specialized help. So we will be providing links to the HERO pages and so on. So with that, are there any questions from the audience? Anyone who wants to unmute themselves and speak up? Love to hear from you.
I have a question actually. That was, can you hear me okay?
Yes. Hi,
Yeah,
Jackie.
okay. That was great, Christian. Thank you very much. One of the reasons that I was really interested to hear your talk today was the fact that it was focusing on dilated cardiomyopathy. So at St. Paul's, we run a monthly ICD education session, and I do get quite a few referrals from Dr. Ong with the hypertrophic clinic, and I don't see as many with the dilated cardiomyopathy patients. And in one of the slides, you did mention that the need for ICD at 5 years with this group of patients isn't as high. Is that what you would say in general with this type of cardiomyopathy compared to hypertrophic?
Well, it depends. This is in particular in the MYH7 related. So I just like gave a few examples because actually we can speak longly and widely about each of the genetic DCMs is actually a matter of a presentation on its own. So I just threw in a few because, for example, even physicians sometimes confuse the MYH7, for example, can cause hypertrophic and dilated. Different is the same gene, but different mutations. The prognosis is not the same. And I just put this in because has this early manifestation in 16%, even in the pediatric age, because usually when we see the patient, their families, and they will refer the children and we test and we can reassure the parents and say usually under 2025 nothing happens. So they have a normal childhood and don't need specialized medication or anything. But some genes may present earlier. And other genes have very high risk of malignant ventricular arrhythmia, yeah, for like LMNA or RBM20, FLNC. So this is why it's really complex and needs a specialized clinic. So it's not everybody the same. And in the guidelines, we are going away from a purely just the LVEF-based risk stratification already, yeah. And the upcoming Canadian guidelines will also go for this. We will in this category. Yeah, the risk stratification is gene-based. Yeah, we are now here. So we classify now DCMs based on the genetic substrate. And sometimes actually it's even more complex than that. It's sometimes even mutation-specific risk stratification. And this is what will come up in the future.
Okay, I understand. So it's more mutation dependent than it is simply dilated or hypertrophic.
Absolutely. It's this gene dependent. So what is the cause? Is it a genetic cause? If it's a genetic cause, what is the gene? What is the mutation, right? And then the phenotype. And this is, so it is getting very, very complex, but this is how we have to evolve because this is why I put in this picture. It's DCM has historically been treated as like a melting pot, yeah, a salad bowl, a ratatouille, call it as you want. Everything was lumped together. And this was wrong. It was only right in terms of heart failure medication. They all get the standard quad therapy. This is correct. However, with regard to prognosis, device decisions, and all these advanced heart failure options, it's very different. When I have a cardiac laminopathy, I already early on, right, tell my colleagues from the transplant team, don't waste too much time, yeah, on like trying to up-titrate the medication. They don't tolerate well. It's not going to work. The response to cardiac resynchronization is very modest. Like if this is a candidate, start early on your advanced therapy because the ventricular ejection fraction will not go up. In contrast, if you have a TTN, a Titan cardiomyopathy, yeah, there it is worthwhile to spend more time on titrate medication. You have a good chance to increase the ventricle. So it's really a gene-based decision-making and management.
Hi. Okay, that's really great. I think, Greg, are you still there? And do you have a question? You looked like you did have.
Yeah, I was going to thank Dr. Steinberg for that. Laminate patient started run the DCM Foundation in the U.S. and thought that was an excellent presentation.
Thank you.
We're focusing heavily on genetics, and we have a group in the U.S. called GCAC, 8 sort of cardiomyopathy groups, and we're tearing down the walls of hypertrophic ACM, DCM, because on a genetic basis, you really need to look at the genes, not it's DCM, HCM, because the genes, as you said with MYH7, can manifest differently. And it's interesting because a lot of doctors aren't looking at it like that, so.
No, you're right, but thanks a lot. I'm glad to hear this. I kindly appreciate your comment, and Ms. Husband already introduced you to me because I think this is highly interesting, your work. This is what we have to do in the future. I think the reason why a lot of doctors don't think about it is because they are not trained for this. This is the cardiogenetic clinics. This is not just standard electrophysiology. We all do like in a double fellowship. This is new. We are the first or second generations of physicians who have been trained in that. And it takes time to spread it in the communities. I give a lot of talks or do teaching because, first of all, think about the reason, right? And then send it to a place. And this is why it's also important that it's not like everybody prescribes a genetic test. At least now in Canada, it's recommended only specialized because it's not so easy, right? So you can have a truncating Titan variant, maybe it's meaningless. And before you scare the entire family and order 15 tests for all the other family members, yeah. So I think it needs like a central hub. And what we do in the cardiogenetic clinic is what I just outlined. And I also give a lot of talks to our heart function clinic. So we are not in competition. We work together. You guys titrate the medication, all that. And I don't titrate immunosuppressants for heart transplant. I'm not trained for that. But for example, we can help to assess, we can help with prognostication of patients, right? And this is what we know learning, right? That which patient needs more advanced therapy earlier than another, as long as we don't have gene therapy. So I think we are still a small group in the country, huh?
Makes sense. And, the Canadians are so much more advanced than the US in percentage of people that get genetically tested and things like that. It's interesting where what you're describing, these cardiogenetic clinics are very few and far between within the United States, and very little testing actually goes on. So kudos to what you're doing in Canada.
Yeah, this is surprising. We see this because you have these huge reference centers like Mayo or Cleveland, and you have top centers who do a lot. But I think the problem is a lot of the DCM patients or also HCM patients, they are absorbed by smaller hospitals who are not necessarily have this trained staff or are linked to such a network. Because what we also do, we learn from each other. For example, on Hero, didn't have the time for that. We regularly on anonymous so we discuss cases on an anonymous space because we have a mutation. We struggle even among us, and it is very, very, very rewarding and also helpful to get input from your colleagues from all over the country. So we forward cases, just as I did outline, right, without any identifiers, sometimes images, ECGs, and have a variance. What do you guys think? This is new. Could it explain? Could it not? What should we do? And it shows that we still have a lot to learn. Huh?
I might add, it also is so important, and you bring that to your presentation, that patients who are symptomatic and or even diagnosed with some of these conditions really require a referral to the specialty clinics, because that could make a difference to them in terms of the choices that they're offered for treatment and so on. And so we at the Canadian SADS Foundation, as a patient support group, hope that we can in fact facilitate that for patients across the country. So thanks very much for your insights, and thank Greg for his perspective from across the border. It's Greg and I were at an international meeting of patient organizations in Europe just a couple of weeks ago. So it's very interesting to see what's going on across the world. And it's wonderful to see that Canada competes and can be right up there with the rest of the world. So are there any other questions? Great afternoon. And be sure to pass this information on to any of your friends or colleagues or family or whoever are the people that are on the meeting with us today. And as I said, we will be putting another posting out into social media with regards to how you can access this. You can certainly go onto our website and access it now. It will take you to YouTube. So I don't have anything else to say. So thank you very much. And thank you so much to Dr. Steinberg.
Thank you very much for having me, for the opportunity. I appreciate. Have a good afternoon, everyone.